Awesome. We are live. Hope everyone's having a great night. I'm Nick Shelby, and we're going to have some fun tonight. Tonight we have Bill Berg on the call. Bill is with Cairo Billing. And Bill, go ahead and introduce yourself and tell everyone a little bit about what you do and who you help and everything like that.
Hey guys, happy Thursday night. My name's Bill Berg, like Nick said. My wife Shannon and I own Cairo Billing, and basically we're a company that specializes in the development and growth of chiropractic practices across the country. So we do billing, but a lot of what we do is we kind of classify ourselves as a support company that billing is one of the things we do. We are a consulting firm, but we only do chiropractic. We're firm believers in the chiropractic principle. As you probably, a lot of you know, we're very involved in AMPed. We love AMPed. It's one of the best, I'd say the best system out there. It absolutely is awesome. The movement of the amount of lives that this program changes is staggering. So we're very proud to be a part of it. We take that very seriously. We are very passionate about it. So if there's ever any situation where any of you want to reach out to us individually, you don't have to be a client, and you'll never have to worry about a sales pitch from Shannon or I, because that's not how we do things. We are here to help, just like you guys are here to serve practice members. We are here to help doctors in any way that we can. So Nick asked me to talk a little bit about what we do, but more importantly, kind of the meat and potatoes of insurance. We'll kind of go through some of the basics, and then any questions that we can answer, I'd be happy to do that. So what is insurance? This evil I word, you know, this villain that everybody talks about and you guys are scared of in school because Medicare is going to kick down your door and arrest you. Insurance is basically, the way I classify it or the way I look at it, it is a part of our culture. It has pluses and minuses. So let's be honest. If we had our druthers, if we had our way, we would be cash practices. I mean, let's face it, it'd be easier to just charge our cash rate and move on. The fact of the matter is, though, that people spend hundreds of billions of dollars a year on health insurance premiums. And if they can use their benefits, they want to. And if it makes sense for you as a practice to be able to incorporate that into your business model, there's no reason to fear. There's lots of help out there, and there's ways to do it. I hear a lot of times, and we're in a lot of other chiropractic circles as well, but almost like I refuse to let insurance dictate the care I give my patients. And I totally agree with that. And my answer to that would be the only time that it will is if you let it. One of the things that we really work with is talking about how to transition your practice members from insurance into wellness care, what that all means, how to phrase it to them. But ultimately, you know, one of the things I constantly say is we work with insurance as a courtesy to our practice members, but we do not let it dictate the care we provide. The care that we're going to recommend to our patients is the care that they need. It has nothing to do with who's going to pay the bill, because quite frankly, the amount of money that will be paid for the care is insignificant to the value that it receives. It's invaluable. So I just say keep that in mind. And I even think sometimes doctors get this feeling like they're betraying the profession if they work with insurance. And I just don't think that's the case. I just think it's just a way to help your practice member maximize their benefits if possible, but not letting it stop you if it's not. So that's kind of what we help with. A lot of what we do, it's a lot more than just submitting claims or just, you know, processing payments. It's a lot of emotional support, a lot of you know, being there, having gone through this many, many times. I mean, you guys are going to have tons of buildup coming into this. Money, time in school, all of this stuff. And then all of a sudden, you're going to be standing in your own front office going, ooh. And, having somebody that can be there with you, it can be very valuable. So when we talk about insurance, basically, I try to keep it simple. So insurance is really just a cost share between the practice member and the insurance company. And it ranges anywhere from 0% to 100%, meaning 0% the patient doesn't owe anything to 100% the patient owes everything. And really, just keeping it simple and figuring out what that means. So it starts out with the practice member, and this is very important to remember. The practice member, the contract is between the practice member and the insurance company. We get involved as a courtesy because the way insurance is intended to work is the way the insurance company looks at it. It's just like if you go to your MD, the claim is billed and then the patient is charged based on how the claim processes. Well, of course, that's outside of what works for us with the care plan model. So we're trying to estimate benefits in advance so that we can present a care plan to the patient. But it's important that we communicate effectively with our practice members so that we don't get in between their insurance and them, because ultimately it is their responsibility. That being said, we help you learn and understand what it is to look for so that you can very closely, accurately predict that. So let's just put it into perspective too. You're going to be recommending a 50, 60 visit care plan. Typical average insurance might cover between 12 and 20 visits. So oftentimes the difference between no insurance and great insurance is less than a couple $100 on a care plan. But it's that perception that they can use their insurance that helps. So I say that because it's not a big deal for them, but it also shouldn't be a big deal in your mind. And practice members are like dogs. They smell fear, so they react to what you present. If you fear that, if you are giving off the vibe that it matters whether their insurance covers or not, then they're going to pick up on that. If you give the vibe that I believe you should sign on to care whether or not your insurance covers or not, and if you don't, hey, maybe it's just not your time in our lives, but maybe it will be at a different time. So those are things that we walk through. So when we're talking about health insurance, so it starts with the practice member getting in contract with the insurance company. And so basically they pay a premium, they pay a bill to Blue Cross Blue Shield or whomever to get this coverage. So they select the coverage, or their employer selects the coverage package that they have. So there's a couple of different ways that practice members owe money. So what their cost shares are, okay? So there's some terms that you probably heard a lot of, but maybe aren't 100% sure. So we've got, really there's two main, I'll call them scenarios, that practice members are responsible for. So we've got copay, which is COPAY, okay? That would be scenario one. And then you've got deductible / coinsurance. That would be scenario two. Okay. So copay, scenario one. Copay is a flat dollar amount that's assigned to a service. So anytime, if you have a copay that's assigned to that service, so maybe adjustments, if you had a $20 copay, that means that the practice member owes $20 for each covered visit, and the insurance company reimburses the difference between that and the allowed amount. Scenario two is deductible / coinsurance. I say slash because they usually go hand in hand. So deductible, everybody's heard of a deductible, very similar to what you'd see on your car insurance. So if a practice member has a $500 deductible, that means they're responsible for 100% of care until they reach that $500, okay? So once that's met, once that deductible's been satisfied, then coinsurance comes into play, which can be a little confusing because it sounds so similar to copay. Whereas copay is a flat dollar amount, coinsurance is a percentage split. Typically 10, 20, or 30% are the most common. So if a person has 20% coinsurance, that means after their deductible is satisfied, they're responsible for 20% of the claim, and the insurance company is responsible for 80%. And I'm going to take just a quick second to jump back and talk about allowed amounts. So one of the things that when you decide whether or not you want to be in and out of network with an insurance company, one of the main things that you agree to is to accept their fee schedule. So an insurance company will assign a dollar amount to a service, so 98941, which is a 3 to 4 region adjustment. Say it's $40 for that service, but we might bill $50, but we agree if we're going to be a network that we'll accept that 40 and we won't balance bill the patient. We won't charge them the difference, okay? And all cost shares are calculated using the allowed amount. So if it's $40 and they have a 20% coinsurance, that means that the practice member will be responsible for $8 and the insurance company will reimburse us $32, okay? So those are the most common things. One of the tricky things about chiropractic too is that we are going to deal with three, for the most part, three different service levels. So we've got office visit exam, which is a generic code. So if you go to any doctor, MD, podiatrist, chiropractor, and they do a new patient exam, that's a generic code. That's a universal code, I should say, not generic. So that would be the same exam code that they would use in any office, okay? Then we've got diagnostic x-ray, radiology. That, again, is a code that can be used in other, other services. Other specialists can use that radiology, obviously. And then we've got chiropractic services, which is typically the adjustment. So theoretically, we could have three different coverages on one claim. So if we build an exam, x-ray, and adjustment on the same visit, which you likely wouldn't, but let's say you did, you literally could possibly have three different coverages for that claim. So the important thing, and you know, a lot of this will make more sense, especially those of you that decide to join our family. We do in-depth training on that a couple weeks before you open. So we help you really understand that and nail that down. And we talk about how to calculate the care plan, how to build the insurance in, how to keep it simple when it seems like it should be more complicated. So again, one of the things that gets confusing is chiropractic, and what we're trying to do is we're operating a little outside of the way it's intended to work, because we're going to be billing multiple services. Because normally you go, if you go to the doctor, you go 1 or 2 times and then that's it. So you got 1 or 2 claims you pay based on how the claims process. What we're doing is we know we're going to bill multiple services, 12 to 20 on average. And then we also know we're going to be performing services that aren't covered. So and then we're trying to calculate that. Not trying, we are calculating that all into a care plan, and we present that to Mr. and Mrs. Patient as we wrap it all in one neat package. All of the visits that your insurance covers, all of the visits that it won't, we put it all together. Here's your care plan. Do you want to pay in full or would you rather pay monthly? And it really is something that we can help you. It's make a lot simpler than it can be. So that's a lot of what we do, you know. And I'm going to talk for a quick second too on one of the biggest questions or things that you'll deal with is what is covered, active versus wellness care. That's the constant, like, why can't all of my care be billed to my insurance? So when we decide to be in network with insurance companies, one of the things we agree to is we contractually agree to abide by the guidelines set forth by the insurance company. While honestly, we probably think they're ridiculously stupid, it's part of the world, and that's what we have to agree to. But we can do that, and we can still provide the care that the patient deserves and needs. It's just a matter of understanding it. So as doctors, you're in control of what's covered and what's not technically, because active care or acute care could also be called corrective care. So when we're in that initial care and we're correcting the symptoms that we that they're coming to us for, that is the part that's covered. So when we're removing the subluxation, or when we're in the corrective care phase, once care becomes supportive rather than corrective, it becomes maintenance or wellness, and in most cases, it's no longer covered. So I have verbiage from the Medicare, actually the Medicare manual. I don't have it right in front of me, but it literally says something to the effect that any treatment meant to promote health, prevent disease, or prevent the deterioration of a chronic condition is not covered. I mean, it's ridiculous that somebody put that in writing and thinks that's a good policy, but that's what it is. So it's basically that average range. You know, my good friend Dr. John Davila would say 12 visits, and I agree. And I, as a biller, say, yeah, maybe we could hedge and 12 to 20, but we're still pretty conservative. But it's not always about pain. So it could be that a practice member is still in pain, but the insurance company will say, well, as if the condition is stabilized, if they're not improving, then we're just holding it. We're no longer correcting it. So what we do is we go into care recommending to the practice member what we feel as provider, what you feel as provider would meet the definition of what the insurance company deems medically necessary. Okay. And again, that's stuff that we train on in detail, support on, and help you understand how to verbalize that to your practice members. Okay. So those are the things that most times come up with insurance. And of course it sounds simple now. There's a lot of moving parts to it, but I'm like, kind of feel like Rain Man of insurance. Like you can't see, I just see it so much all over the country that it makes a lot of sense to me. And sometimes I don't want to make it oversimplified, because when you're not used to dealing with it, it's like, what in the world does this mean? But our goal is to make it as easy as possible. And really, and I say this with 150% sincerity, the lives that you'll impact are staggering. And the amount of lives that we're able to indirectly impact are very humbling. I mean, and we really, really take that seriously. So we develop a very close bond with the office, and that's the offices that we really do well with, ones that we become part of the team, and we believe in your mission as much as you do. And nothing makes us happier or more satisfied than when the office flourishes. So many of the superstars that you see up on stage were in these very hangouts and had the same uncertainty and fear, and believe me, we've had some good laughs with some of these offices on what in the heck we were thinking the first week and 6 months in. So nothing makes us happier or prouder than when we see people that we've known from school become these rock star doctors impacting lives, and we're able to help with that. So, I mean, I could go on and on and on. I know you guys are going to have some questions. Nick, does that kind of hit the bases? Do you want me to touch on anything else, or?
That was amazing. That was really, really, really insightful. Thank you. Yeah, that was amazing. So, I guess the only other definition I'd like before we get into some of the questions, and maybe this is a little in depth of a definition, but we're just going to do it anyways. What exactly is a super bill?
Okay. A super bill. So you've got a couple of different options when we're talking about insurance. We'll talk about right now what it means to be in a network. Okay. So the only network that we're legally required to register with in order to treat practice members is Medicare. You have to register with Medicare or you cannot even treat anyone with Medicare. Okay. Medicare covers active adjustments only, acute adjustments only. That's it. There's two ways that you can register with Medicare, participating and non-participating. Okay. The main difference between the two is with participating, you agree to accept assignment. So, and what agreeing to accept assignment means is that you bill insurance for claims and the insurance company pays you directly less any out-of-pocket costs that the practice member has. Okay, so basically how you would expect insurance to work. You give your doctor your health insurance card, they bill Blue Cross or Medicare, whoever. Medicare pays them less anything you owe, and you owe your portion to the doctor. Okay, so you agree to accept assignment. So Medicare, you legally have to submit claims on behalf of practice members. You cannot allow them to do it on their own. If you're in network with any commercial insurers, and when I say commercial, Blue Cross, United Healthcare, Aetna, anybody basically other than federal programs like Medicaid or Medicare, we'll consider those commercial networks. If you're in network, you are agreeing to accept assignment. So you are obligated contractually to bill on behalf of the practice members and then receive payment. If you choose to not be in network or participate with insurance, you can choose to not accept assignment. And a super bill is a form. The pure definition of a super bill is basically a claim form that you can give to patients that they can submit to the insurance on their own. Okay, it has the CPT codes, the codes that you perform, diagnosis codes, and your office information. So it basically sends that. The biggest thing that I want to make sure that everybody knows, though, is you're not any less liable for documentation or compliancy by giving a practice member a super bill or whether you bill the insurance. Because, as silly as this sounds, we have to remember that these are not car washes that we're giving away. These are medical procedures that we're performing. So it's not about like, hey, I get 30 visits, sign me up. It's about you as a doctor have to be able to justify the care. When you go to an orthopedic doctor and they bill your insurance for setting a fracture in your arm, they don't just send that claim in because they think that might have been what happened. That's what happened, and they would have the documentation to stand by it. So a super bill is basically it's a bill that you can give your patients that they could submit to insurance on their own. That would be if you're a non-network provider. Now, many of you, I don't know who's exactly on this call, many of you may work in offices or been involved in offices that we work with. We have a super bill a form we call our super bill that is really a diagnosis sheet. So one of the services we provide is doctor diagnoses the practice member, fills out a quick form, sends it over. We enter all of your diagnosis information into your software, whether it be Platinum or ChiroTouch, and enter insurance information and make sure that it's billed out. The reason that we do it that way is we want to make sure that the diagnosis codes that we're sending are matching up with the guidelines that the insurance company is going to want. Because really, when we're in network with an insurance company, we're kind of like on the honor system. Okay, so we're agreeing that we're going to provide care and only bill for covered services. So when we submit a claim, for the most part, they're thinking that's what we're doing. And I kind of call it like the keyhole. We give enough information for the claim to get through the keyhole, because most claims are not looked at by anybody. They have just enough information for the system to process automatically. Okay, and so a super bill is basically, if you're a non-power provider, you can give that to your practice member and they can submit it on their own for reimbursement. Again, one of the things, because there's going to be networks, even if you want to deal with insurance, there's going to be networks that we may decide together that there's more bads than goods and it's not worth it. Or there might be networks that aren't open right now. They're not available and we can't get in. So one of the things we help with too is when you're opening, we help you decide or quantify what networks we should do and what that means, but also, you know, how to deal with strategies with practice members for networks that we can't be in, okay, and what to do with that. So does that answer that question?
Yeah, that was cool. Thank you. So I think right now we are just going to go through the list. We have about 16 questions from the Facebook group, which is awesome. We had a ton of this week. So we're just going to go right down the list, and we'll hit on a whole bunch of topics, and we'll just see.
Perfect.
So first question comes from Kent Replogle, and Kent says, what are the major changes that are happening with insurance with Obamacare starting to be taken apart? What are the main things we need to know about that?
Okay, so the biggest part of the ACA was the fact that insurance became mandated. That was the big thing. It really stirred the insurance because when insurance companies, I mean, they're actuarially, they have to have enough money to pay claims, right? So they're always predicting how much money do they have to have. So it makes it difficult when they can't control who's under care. So you've got somebody, you've got two people, let's say. You've got a person that doesn't go to the doctor, healthy person that has insurance, and then you've got, you know, somebody that has, you know, type 1 diabetes or something, or, you know, so they're going to pay premium, but obviously the premium from the guy that doesn't go to the doctor offsets because there's sick people that don't pay enough premium to cover their care, right? That's how insurance works. Homeowners, auto, any of that. So the big change with what happened with Obamacare is it made the insurance companies have to cover everybody. Okay, so that's a scary thing. As heartless as it sounds to think that you turn somebody away, it also is a, you know, financial. They have to be able to pay the claims. So the main thing that I see with the Obamacare going away is the people that had purchased marketplace plans, which are, so you've got two different types of insurance. You've got group insurance, which is provided by your employer, okay, and then you've got individual that became more common with Obamacare because people had to have it, okay. The have to haves, those coverages weren't great anyway. They usually had high deductibles, high out-of-pocket costs. So for the most part, the practice member was paying out of pocket anyway. The group insurance, the employer-paid plans, is where you get the bulk of your insurance coverage, okay? So I don't see it having a real direct impact other than right now the people that had the individual plans that choose to no longer have the insurance will just be cash patients, but they likely would have been anyway. So now I'll also say I don't think anyone knows what's going to happen. I mean, I think the president had to get a victory, and they tried to take Obamacare out face on, and that didn't work. So they cut the legs out in another way, and now it's going to crumble. But we'll just have to see. One thing, though, that's certain is things always change. I have hope that things are looked at in a little more of a non-traditional way. And honestly, I hope that chiropractic is more recognized for its benefit to reduce cost across the board. And I really hope that we'll see some of that. I think we're going to see some chaotic times in the near, but I don't think it's going to really impact the I don't think it's really going to change things much. I think we'll have to see what the replacement is, then we'll talk about what real changes we're going to see.
Gotcha. No, that was really insightful. Thank you. Next question is from Brandon Hart. And Brandon says, in some cases, I see docs talk about practice member out of network benefits actually being better than the in network benefits. How does that work? And also, will the office be able to choose which benefits to use for the practice member, even though they may be in network with that insurance?
Okay, great question. So there are, in most cases, so there's two basic main insurance networks: PPO, which is Preferred Provider Organization, and HMO, which is Health Maintenance Organization. Okay, PPO network is primarily when you hear somebody in network, that's the network they're in. And a PPO network is a very broad network, and for the most part, the practice member can go to any doctor they want within that network. HMOs are managed care. So typically that means that the patient has to coordinate care through a designated primary care physician, so usually an MD, that before they can go to another doc, they have to get approval or a referral, okay? So it's very common for PPO plans to have both in and out of network benefits, okay? It is, I would say 97% of the time, the cost share for out-of-network benefits for the patient is much higher than in-network. So in most cases, the in-network benefits for the patient are much better than out-of-network. But there are rare occasions where there would be better out-of-network coverage than in-network. But it's typically, so if on average, let's say somebody has $1,000 in-network deductible, almost always the deductible out-of-network is at least double. In a lot of cases, it's even more than that. So I would say out-of-network with people having actual billable benefits, it's a very low percentage. When I say billable, where there would be any reimbursement from insurance. There are some pockets of plans, though, like union plans, like they're called self-funded plans. So, like say the pipe fitters or Teamsters, they may use like Blue Cross Blue Shield to manage their claims, but they offer they don't necessarily depend solely on their network. So the coverage could be very similar for in and out of network. But for the most part, it's much better coverage in network if there's good coverage. And as far as being able to choose benefits, no, you can't do it. If you're in network applies. You can't choose to be, I'm going to be in network with this plan and not this plan. You can choose based on the company. So you could say, be in network with Blue Cross, but not in network with United Healthcare. You could do that, but you can't, you can't opt in and out of specific plans. And one of the things we do, so I guess I'll just back up a quick second and say back to how we do things. Shannon and I split responsibilities quite a bit, and I work with the offices in the beginning. I handle all of the enrollment, credentialing with insurance companies, but I'll also go through each network for your area and talk about why this would be good or maybe not, and what it means to be a network, and specifically because one of the things that we just have to be careful is with the massive amount of awesome docs in AMPT is they're spread out all across the country. So a doc in Florida is going to be a lot different than a doc in Michigan or a doc in Colorado. The networks are different, the requirements are different. So we really want to make sure that we are we're getting, looking at the right comparison. Does that make sense?
Yeah.
Okay.
Yeah, that makes a lot of sense. Thank you. The next question kind of ties into what you were just talking about. It's from Brandon again. He says, is there a website that allows a new office to see what major insurances practice members use in their area? And do you recommend getting in network with them immediately or waiting a few months after they open?
Okay, great question. That's a really good question. So Not really. There's not like a universal website. I mean, I'm a good resource because we have offices in, I believe we're in 43 states. So uh, I mean, I've done hundreds of enrollments, so I know a lot about it. One thing I will say is I usually recommend to new docs it's a win-win. So every area for the most part usually has one or two health insurance agents. So they have somebody that's like the go-to guy or gal for health insurance. So a great thing to do as a new doc is network with them, go to them, set up a meeting, say, hey, I really want to make sure that the patients in our area, I am in the right insurance companies. What would you recommend? What are you going to see most of? And then that also then gives you an opportunity to network with a LinkedIn person in the community. So that works out good. I will say this: you can have two offices 5 miles apart that see totally different insurances. The reason is, like I was saying earlier, most of your coverage or covered individuals are going to have group health plans. Their employer pays. So the industry in your area and who you treat, you're going to get referrals from. So you're going to see a lot of people with the same coverage. So if you know that a company in your area uses Blue Cross Blue Shield, then you're going to know you're going to see a lot of that. So what I usually do is we talk about the national networks or the main networks we're going to see. And then I always talk to our practices about, hey, this is a work in progress. So we look at it, yeah, we want to be a network with as many, if you're going to be a network from day one, but we might want to wait on some networks based on maybe they've got some restrictive billing guidelines, or maybe their fee schedule isn't that great. We really want to make sure that we're going to see practice members with it with billable benefits before we jump in. So it could be possible that we'd want to wait. But like normally what we do is Medicare, Blue Cross Blue Shield, United Healthcare, Aetna, the main national networks, the big ones. But there's almost always localized or regional insurance plans that we might want to look at, and say, hey, Bill, I'm seeing a lot of practice members with this. Let's take a look at this insurance. So it's not like a one and done thing, especially if we're billing, if you're on with our billing service, that's part of our ongoing service. So we react to that. As far as when to get in network, so you can't start anything until you have your state license and your location secured. So you have to have your treating location. In order to be a network, you have to have a physical location that you're going to treat patients. So you can't use like a PO box or your home address until you get. So the minute that you sign your lease and get your state license, if you want to move forward, that's the time. Somebody asked me today, when's the best time to get in network? I kind of say, well, it's the same. It's like, when's the best time to plant a tree? It was 20 years ago. What's the second best time today? So it really depends a lot on your story. Not everybody has, some offices have 4 or 5 months before they're opening. Some offices have 4 days. We've done it all. Some offices start after they decide they don't want to be in insurance and then realize later on that that's really not working for them. So they want to be. We can react to that. Timing wise, the average enrollment takes 60 to 90 days, 60 low end, 90 average, and even sometimes it runs a little bit longer. So if you are going to work in insurance, the sooner the better.
Awesome. Thank you for that. Next question is from Brian Hewitt. Ryan says, hi, Bill. Glad we could catch up at conference.
Yeah.
What are some key points that we need to pay attention to that can vary from state to state with billing? And what are the positives and negatives that you see with some states?
Oh, that's a tough question. So there are, I'll call them some insurance states are better than others in reimbursement. So, there are states that have more challenges than others when it comes to insurance reimbursement. But I honestly, here's the thing. The days of running a practice that are heavy with insurance reimbursement are long gone. The Mercedes 80s, they're gone. I mean, it used to be 90% insurance, 10% cash, if any. And now that's flip-flopped. And that's why AMP is so awesome, because we're really only using insurance to get in the door. So when we're talking about a state, like if you decide that you want to open in Florida, I mean, I wouldn't not do it because their insurance is a little challenging there. You got to do it for the right reasons. You're never going to open a practice somewhere because you're going to make a lot of money in insurance. The key points, I think, are your ability to integrate into a community. I can certainly talk to you about any state of, what it's going to mean. But, there's states like Nebraska. Nebraska uses a network called Secure Care for Blue Cross Blue Shield and other networks. You got to pay to be a part of, which stinks, but they reimburse really well. So, I always try to look at the silver lining. There's always a reason. So I can't really give you an answer as far as like, what should you look for? It's more important about what does your heart tell you and what is bringing you to an area, that you got to see people because we're going to make hundreds of dollars from insurance and thousands of dollars from cash. So if it's where you're going to open the practice that you're going to be able to impact the most lives possible. Hopefully that helps.
Yeah, that was really good. I know that's something that we talk about in club, and when trying to decide where to pick a location, it's always go where your heart is.
Mm-hmm.
You feel called to go. So it's kind of nice for that to be reinforced and to not let some of the rules or insurance or anything like that get in the way. So thank you. That was good. Next question is from Rachel Woods. And we touched on this a little bit, but we'd love to go a little bit more in depth. What are the steps do we need to take before we submit to be in network with insurance? So an EIN, NPI, tax ID, verified provider.
Okay. So I'm just going to answer that from the assumption of we're going to work together, and then how we would react and what we would want you to do and what we will take care of for you. So the things that you as docs will need to do is secure your location, obviously, get your state license. You'll need to get your EIN. Here's one thing I highly recommend. Make sure that your legal business name, as you register it with the IRS, is exactly what it is. And when I say exactly, make sure that when you file for your EIN, that if it's LLC, if your legal billing name is, Bill's Wonderful Chiropractic LLC, that you put LLC on there, because Medicare is particular, and I will be coaching you on how to fix that if you don't do it that way. Another thing is a lot of times we'll do like DBAs and then legal business name, which is fine. It just can be a little bit confusing because sometimes practice members get confused when they see like, for example, our legal business name is Complete Practice Management Incorporated. I say that and people are like, who's that? But you know who Chiro Billing is, right? So it's the same kind of thing. So you secure your legal business name. I highly recommend getting tax counsel on how to organize your, there's certain things that you can do on your own, and there's certain things that you should get guidance on, because if you have to change it later, it can create a lot of work and it can create delays in reimbursement. So if you start out as a LLC, but then you want to file as an S corp, talk to somebody. There's a couple great resources. I know that Greg Hammonds is really good about helping you set up the right way first. As far as national provider identification numbers, MPIs, those we get for you. So I'll take care of all of that. You'll have two. You'll have one that identifies you as an individual provider, and then there'll be one for the group. The type 2 or group MPI is a billing MPI. So we submit claims under the group name with you as the rendering provider. As far as getting a network, or as far as what you need, the first thing is schedule a call with me, and I'll go through it all with you and give you the form that you fill out with all the information so that I can just take care of all that for you. Because it's a lot of work, and it can be frustrating, because even when you do it 100% correct, it's a moving target. So it takes a lot of follow-up and work sometimes to get these networks done, and even still it can take longer times. You're just at the insurance companies they don't have to let you in, so it's not like we can complain to somebody if it's taking too long. So it's a lot of work, and honestly, it's just something that you shouldn't have to deal with. You should let us take care of it for you so that you can focus on doing what you are in school to do, and that's change lives. Take the rest of the stuff off, because whether you do it yourself or cost is you got to be careful, because something has a lower price tag, it doesn't mean that it's cheaper. So if you go and you find a computer at the curb or at a thrift store, and it's $20 and a new one's $300, which one's cheaper? It's really hard to quantify that, because if it doesn't work and if it doesn't do so whether you do it or you pay someone to do it, there's a cost to doing it. Does that make sense? So the parts that I want you to do, you'd have to secure EIN. You got to get a checking account, a business checking account, and you got to get your EIN and your location and your state license, and then the rest we can help almost everything with.
Awesome. Yeah, that was really good. And yeah, I think it's important for everyone to recognize that what you're talking about with the cost. There's certain things that just because it's cheaper doesn't necessarily mean that in the long run it's going to pay off the way we want it to. So I think that was really good for everyone to hear. Next question is also from Rachel. And Rachel says, if a practice member has 20, 30, 60, etc. visits covered by insurance, why are we advised to only bill 12 or only bill active care or 12 visits?
Okay, great question. So I'm gonna be a little silly on this and make it using kind of an outrageous example. So insurance only covers active care or corrective care, okay, as they define. So it's not, wellness is just not a benefit in most cases. So it has to meet the clinical guidelines set forth by the insurance company to define as active. So let's say a policy limit has 50 visits, okay? That means that that's the most that can be paid. And I go back to my first one of my first statements that these aren't car washes. So it's not like a free sub at Subway. It's a medical procedure. So we have to be able to diagnose and support the fact that we would have that many visits. So Medicare has no visit limit. So would you say unlimited visits? Technically, but they're based on medical necessity. So it's not that there's no hard stop in most cases where there's 12 or 20. But think of it this way. This is an example I use a lot. Let's say your health insurance probably pays for 60 chemotherapy visits a year. You don't just roll up to the oncologist in January and go, all right, my policy pays for it. Hook me up. Give me my 60. I pay for it. I want it. You got to have a condition that the insurance company would approve that treatment to correct. So an example of that might be you might only be able to get, actual care, chemotherapy to treat a cancer. And if they might not pay for it to keep it from coming back. That's just the way the thing is. So it's not about the visits. It's about our ability to prove medical necessity. Like Dr. Davila, he says, he uses the example, your policy pays for a full frontal lobotomy too, but we probably shouldn't do that today. I take a little softer approach, but that's him and I. Uh, he's a good friend of mine, so we kid around with each other a lot. But I know it's a constant thing with your practice members about why can't I bill my 30 visits? But we help you with strategies, and you just make it a non-issue. We just take insurance and we use it for the ability that we can, but we are the ones that determine whether it can be billed to the insurance or not, based on our understanding of what their guidelines are. Does that help?
Yeah, that was a big help. That was really good. Next question is also from Rachel. She said, talk for just a minute about individual deductibles, what applies to out-of-pocket family deductibles, and if family deductibles or out-of-pocket are met, are individual benefits paid?
Okay, great question. So in most cases, plans have both an individual deductible or a family, or sometimes called a contract deductible. Okay, so let's use and I and our two daughters, we have a Blue Cross plan, and each of us has, let's say, a $100 individual deductible, and we have a $200 family deductible, which is very common for the family deductible to be double with the individual. So once I go to the doctor, and once I've reached $100 of my care, so let's say I'm the only one that has gone to the doctor, and $100 is used, my insurance starts to cover me at my co-insurance rate. My deductible's met, I've satisfied it. Okay, so I met my $100 deductible. $100 would also then apply to the family deductible because it's been met. I can't apply more than what my individual deductible is to the family. Okay, so now I've got my deductible met, $100 of the family deductible has been met, so that leaves $100 remaining on the family. And Shannon, Addison, and Jordan still have their $100 individual deductibles, but and they haven't used any. Okay, so let's say Shannon goes to the doctor, and now she's used her $100 deductible. So her care is now covered at, assuming that her deductible is met, and her $100 deductible has now gone to the family deductible, and now the family deductible of $200 has been satisfied. So our individual deductibles have been met, and the family deductibles now been met. Okay. Now our two daughters haven't used any of their individual deductibles, right? So their $100 remaining. But since the family deductible has been met, now their individual deductibles no longer apply. So once the family deductible is met, individual deductibles no longer apply. And out-of-pocket max, so you've got what we consider anything that would be patient responsibility, whether it be a copay, deductible, co-insurance, those are what are called out-of-pockets. So it's very common, and almost all policies have an out-of-pocket max, meaning that once a patient has paid a certain amount of money in out-of-pockets, a combination of those things, then their plan considers it 100%. So, but I'll caveat that by saying they're usually very high. So they're usually $5,000-$6,000 family or out-of-pocket maximums. So it's pretty rare. I don't want to say rare. It's definitely not the norm that an out-of-pocket max would be met. It would be far more likely that the cost shares are in play. So basically the once the out-of-pocket's met, nothing would cover 100%, but they would really have to have a lot of things going on. So it would have to be somebody with some pretty significant issues going on, because they'd be billing quite a bit to insurance. So does that help that question? Does that answer everything you asked?
Yeah, I believe so. I think that covered it all. So then next question is going to come from Evan Lichtenhauer. And Evan asks, can you explain HSA versus HRA?
Oh, yeah. Good question, Evan. So basically, what has happened in, I kind of started out way back with even prior, but really started to come on the market with when President Bush was in office, where they start having high deductible health plans. Okay. So what happened is with these high deductible health plans, they started having different methods where people could offset or save money to offset those deductibles. So let's talk about an HSA first. An HSA is a health savings account. Okay, so basically what that is if a patient has a qualified high deductible health plan, they can create they can have an HSA account where money is put in and it's an above the line deduction, meaning it's pre-tax money. And as long as they use that money for qualified medical expenses defined by the IRS, it's tax free. Okay. So I have an HSA. It's basically it's an account in my bank that I can put in up to, I think it's $5,500 or $5,000 per year, and it's tax free. And I have a debit card, and I can use that card anywhere. And so, if somebody comes into your office that has a true HSA, they can use that card for any part of care. They can use it to PIF, they can use it for deductible, they can use it for cash visits, because chiropractic is a qualified medical expense as defined by the IRS. So is aspirin, by the way. So is, a lot of things. So, and the only time that any question would come up is if they were audited. So it's a tax thing. It's not. So they have control of that funds. So as long as there's money available, the practice member or the patient is in charge of that money. That's an HSA. Okay. An HRA is a health reimbursement arrangement. Okay. So I'm just going to explain quickly why those exist. So if you're an employer and you pay your employees' health premium, and let's say for a family it's $1,500 a month, and they have $1,000 deductible. Okay, but you talk to Blue Cross, and if you take them to a $3,000 deductible, it's $1,000 a month. So it's $500 a month savings to the employer. So that's $6,000 a year. Well, but the employer really doesn't want to cut benefits for their employees. So what they do is they create health reimbursement arrangements that will pay the difference for the deductible, so they can still save the premium, because now even if they pay that $3,000 deductible, they're still saving an additional $3,000, right? So you're seeing more and more of that. Typically how HRAs work is, as long as funds available, amounts that apply to deductible are automatically reimbursed by the HRA. So let's say they have a Blue Cross plan, we're in network, and they have an HRA. Let's say they have a $3,000 deductible and there's $1,000 available in their HRA. Okay. So that means when we bill the claim, it'll first apply to deductible, but then it'll be forwarded to the HRA and it'll be paid at 100% from that fund, as long as money's available. Once the HRA's exhausted, now they're responsible for their deductible again. So the trick with those is you've got to make sure that you communicate with your practice member that we can only go off of what information we're given at the time, because it's a first come first serve. We don't know if there's claims that they went and had procedure somewhere else, and now that is going to drain that fund. Okay, so an HRA, you bill insurance typically, and it pays as long as funds are available. There's a third one called an FSA, flex spending account. An FSA is kind of like an hybrid between an HSA and an HRA, but the patient has to give receipts to their employer in most cases. And in those situations, they cannot prepay for care. So they cannot, and a lot of times they don't even want them to be able to make like a monthly care plan payment. So a lot of times with those, we have to help you, show you how to use stop managers and platinum so that you can reconcile the balance every month and then give them the receipt. Because it's pretty common that the patient will come in with an FSA and try to pay in full, and then they end up having to pay the money back because they can't prepay for care. They can only pay for services rendered. Okay. All that being said, is these are some of the most ill-used terms in insurance. They're people hear HSA and they say HSA, but it really isn't an HSA. Or they hear HRA or FSA or flex spending. So it's really case-by-case example, and those are really location specific. So if you, it's like with your insurance, if you see FSAs in your area, you'll see them. It may be you'll never see them. It depends on what the employers in your area, what benefits those patients have, because you'll see a lot of them. In Michigan, teachers have HRAs where the patients have to go online and release the funds. So there's a lot of different variations of these plans, and that's just basically learning what you see and how to react to it.
That's really interesting. I had never heard of an FSA before, so
I hope you never do.
Fair enough. So we are going to do 2 more questions, and then we will wrap it up. This has been amazing. You're gonna have to do this again soon, because we do have more questions that will need to be answered. I'm sure.
I'm just long-winded.
No,
I told you, Nick, I won't shut up unless you shut me up.
No, this is good, because what we do on the YouTube page is these will accumulate. And so, especially when students get closer to graduation, they can come back and they can use this video as a resource. And so it'd be really, really, really good. So all the details that you're giving are really going to help us. So we really appreciate that. Second last question is also from Evan. And Evan says, if someone's insurance benefits for a service are more expensive than our prices, can we neglect to use their insurance, assuming we're in network?
The answer to that question is you are contractually obligated, if you're in network, to bill for covered services and collect based on whatever their out-of-pocket is. Keep in mind that covered services are active care. So if the practice member was wellness, that would not be a covered benefit, and then you would not have to submit to insurance because it's not a covered benefit. But if you're in network, you are contractually obligated to submit for covered services.
Okay, that makes sense. Last question. Let's do this one from Rachel. What happens to a practice member under active care when the year changes and deductibles or out of pocket go back to $0 met?
So the question probably is like, if we start somebody under care in say December and their deductibles met for this year, and then their care rolls into next year. What we do is when we're figuring out the benefits, we calculate what their cost is per visit. So when we know that when we estimate how many visits are going to roll into the new year, then we would account for those being applied to deductible, and we would figure those out. So when you're figuring out a care plan, you figure out the insurance cost, and then you figure out the cash cost, and you combine them into one amount. So what we're really trying to do is just determine what is the patient's responsibility going to be for X amount of visits. So if it's 12 visits and 6 are covered with 10% coinsurance and 6 are going to be subject to deductible, we just calculate what those allowed amounts are, and then we add it accordingly. Another common question is, what do we have to do if a patient's in wellness and come January? Do we turn the insurance back on? The answer is, unless the patient has had an exacerbation or a new condition, then they would remain in wellness care. If you were to do an exam and had findings that would support active care, you could submit more visits to insurance, but they would have to have supporting diagnosis to do that. You can't just turn on the insurance January 1 because their deductibles reset. Does that make sense? Or their coverage reset, rather. Like if they get 20 visits a year, you can't figure in 20 visits this year, 20 visits next year, because there's going to be a period where they go into wellness. You could theoretically have that happen, but most of the time it's when the plan renews and you do another re-exam, or if they, if they have if they have something come up that would put them back into active care.
Gotcha. Okay. No, that makes a lot more sense now. Well, I think that is going to do it for the night. We covered a lot of good stuff, and that was a lot of great information. So thank you, Bill, for getting on this call and for sharing some of that with us. Can you kind of give everyone your, whether it's social media, website, phone numbers, how we can reach out to you if we have questions?
Yeah, and I really appreciate you guys having me on. I mean, I hope you can see that I really, truly love this. And I really mean this with the bottom of my heart. I love doing this. I don't expect, a return on investment. So don't ever hesitate. I love doing these calls. So I'm happy to do it as often as you'd like. And anybody out there that has any questions or wants to schedule an individual call, I absolutely love to do that too. Best way to reach me is email Bill, BILL, at chirobilling.net. You can also go to friend me on Facebook. Hopefully everybody on here, we're already friends, but if not, friend us. It says Shannon and Bill, but it's usually me that's answering the Facebooks. And in my phone number is 810-637-5064. I try to schedule all calls, though, because I want to be able to make sure I give you the attention that you deserve. And so I will absolutely slot time for anybody with any questions. If you want to talk about states, if you want to talk about theory, if you want to talk about, that you like my hair. I mean, anything you want to talk about, you can call me. But I really appreciate it. We love the profession. We loved AMPed, and we love all our doctors. So anything we can do to help, we're here for you.
Awesome. Well, we love you guys, and we really appreciate you being on the call. So I know we didn't get to everyone's questions. We have a couple left. So if your question wasn't answered, make sure you reach out to Bill and Shannon individually and get that handled. I'm sure me and Rachel will be doing that for some
awesome
too. So, yeah, Bill, we really appreciate it. Thank you so much.
All right. Have a great night, everybody.
You too. Take care.